Can I have my first slide? Okay. Well, I won't be able to touch everything on here, but this is a large topic. These are my disclosures, 2 seconds worth. In the year 2000, the AUA summoned the 8 or 9 sub-societies to choose the best, the most important publication in their field. In our field, the SMSNA chose this article on the inflatable penile prosthesis by Brantley Scott. We all know he was a giant. He had the inflatable, the AUS and the Scott retractor. We know at the turn of the century that infections occurred in primary implants in about 3%, and in revision implants about 10%, 18% in diabetics, and staphylococci were the most common species. We learned also that there was the race to the surface. These are bacteria actually colonize, they attach to the prosthesis and secrete a polymix matrix and form a biofilm that protects them from attack. The inflatable penile prosthesis by AMS was the first to actually incorporate minocycline and rifampin into the actual service. Likewise, around the same time, the proprietary coating, polyvinyl propylene, was put into the biofilm of, into the mentor prostheses, and also it allowed for a water-permeable antibiotics to be absorbed into this and to elute. And if you look at both of these at these contemporary abstracts, you can see that the infection rate dropped from about 60% for both of these types of prosthesis at this time. Francois Ede and his organization, they didn't allow them to use any kind of dipped antibiotics into the dipping solution. So you can see his comparison of over 2,300 prostheses from 2000 to 2003. The non-coated had about a 5.3 infection rate. When he used the coated IPPs that had lubricious surface that didn't allow attachments, there was a 2% infection. And then he basically adopted a no-touch technique where there was a superficial skin and microbes were not exposed because of a plastic sheet, and his infection rate dropped to 0.46%, which is quite remarkable. We learned also from Henry and Wilson that if you do a Mulcahy washout at the time of revision, that the infection rate would drop from 11% to 2.8%. Another thing was from Kohler and McVeary. At their time, they looked at patients who had scrotal pump erosions, and they had 6 men. What they did is they removed the device, washed them out with the Mulcahy technique, and put in a malleable prosthesis. All these patients did well. 2 of these patients actually converted to a 3-piece at a later date. Likewise, Gross actually presented a retrospective multi-center study and looked at 58 patients that also went under this with an infection, not just an erosion, removed them and put in malleable prostheses, and 93% remained infection-free. A third of these patients subsequently went on to inflatable penile prostheses. This multi-center investigation that was published by Gross was studied 227 intra-op cultures at the time of explant or salvage. What was found here is that Candida were found in 11%, anaerobes in 10%, and MRSA in 9%. So their conclusion was that the EUA and AUA guidelines didn't cover anywhere between 14 to 38% of actual infections that occurred. And what they suggested is to broaden the guidelines, if anything, and I think most people now, for immunocompromised or diabetic patients, add fluconazole to their preoperative antibiotics. The carry-on cast, this was basically transferred from the orthopedic literature. Some patients basically are septic, or they have complex medical histories, or they failed prior salvages. In these circumstances, what they've done is put in a calcium sulfate mix with both saline, tobramycin, and vancomycin. They inject this to actually act as a support, and this dissolves over 6 weeks, and you can put a malleable prosthesis in, but it actually prevents the fibrosis and shrinkage of the penis that happens with infection. Autoinflation was also a noxious thing that occurred in about 11% of cases at the turn of the millennia, and 2% of these actually went to surgery. So the lockout valve that was adopted allowed to sort of circumvented this problem. Also, when the abdomen, when the pelvis was hostile and you couldn't place a prosthesis in the pelvis, these devices were placed in areas that were ectopically placed. And this carried over to Maury's presentation, where he actually used a high submuscular placement. He used a forceps lung grasping forceps, you can see in the top here, placed this through the inguinal canal and between the external inguinal ring and the transversalis fascia. And 85% of these patients did not feel the reservoir. 2 had some bother, but both the AMS developed a concealed flat reservoir, and the coloplast had 125 Cs Clover type, which were underfilled, and these were able to flatten out. And this basically prevents anybody, if you have a hostile pelvis, to have to dissect in that area, and it's kind of a protective issue. When talking about priapism, we have both the T-shunt with the tunneling or surgical snake maneuvers. These were introduced by both Dr. Liu and Burnett. And what this involves is either passing, after making a distal incision, and is passing either an 8 or 20 straight urethral sounds proximally to the penile crura. And most of these patients, these had long-standing priapism. Many of them actually did quite well. David Ralph actually presented the immediate insertion of a penile prosthesis for acute ischemia. He had 50 men who had priapism for a mean of 209 hours. All these patients, he was very careful at these times, had blood gas analyses and duplexes that documented no flow. At the time, he actually took a biopsy and showed that there was necrosis of the tissues. He did have postoperatively 12 reoperations, 3 infections, and 6 conversions went from malleable to inflatable penile prosthesis. But this has basically been adopted now, the early insert in the patients with long-standing priapism. The most common complaint with prosthesis, inflatable penile prosthesis, is penile shortening, and this was actually something that was published by Raphael Carrion, and what he did is basically a scrotoplasty where he took a web out, and patients' perception, as we learned in a few days, do quite well. I think a lot of us adopted this. I do a transverse incision, basically close it vertically with clipping of the edges, and a lot of the patients do benefit. They think their penises are longer. As far as tunicle sparing techniques, this is used for if there's surgical indents or hourglass deformities. This was first described by Tom Liu. He had 36 patients, and a lot of these patients did well. They used a graft, they fold it over and put it between the buccs and tunica albuginea. As far as Peyronie's disease, I think we have all sort of recognized that collagenase is a treatment, but this is probably almost close to a surgical approach. This is an aggressive intralesional injection by Dr. Trost that basically injects in successive days and uses very aggressive modeling with 10 to 15 pounds of force, and basically wrapping these patients and then sending them home on aggressive manual modeling. What was found is that the mean composite improvement went from 17 degrees to 27 degrees, or from 24% to 41% from baseline. So this was actually quite an improvement. As far as ejaculation, there was a very important paper that was done, our study was done by Gilles Vernet in Spain, and the concept of ejaculation was that in the past that there was a combustion chamber, and the internal sphincter closed the bladder neck and basically allowed the pressure to build up, and then the external sphincter opened up. So this was basically a new concept that was developed from this. And what he described was that there's an ejaculatory hood of tissue. And this is basically surrounds the area around the verimontanum. And basically, if you were to resect this area, you basically do not affect this 1 to 2 centimeters proximal to the verimontanum and alongside of this. And this allows the muscle to propel in an antegrade fashion. For many patients, the concept of actually preserving ejaculation is very important. So from there, with this paradigm shift in both the understanding of the anatomy and function and the dissolution of this combustion chamber, the preservation of this ejaculatory hood and the smooth muscle still acting allows many men in this area to preserve their erections. And new concepts with aquablation, with Resume, and these different types of techniques have actually shown this. Of course, we have to look over periods of time, and we have to measure the improvement from the urinary, from LUTS, and the preservation of ejaculation to look a long time to see if these are on. So, Ron, I'm on time.
Good. Thank you very much.